Hello, everyone. Very welcome from the Australian National University here in Canberra. I hope that you and your loved ones are keeping safe and healthy. I'd like to acknowledge the Ngunnawal and Ngambri people, who are the traditional owners of the land in which ANU is located and where we are broadcasting to you from today. I pay my respects to their elders, past and present. We are pleased to welcome attendees from various parts of Australia and the globe, including India, Indonesia, Burma, Fiji, China, and South Africa. Knowledge is power, and our weekly webinar series allows us to share and learn from each other's experiences during the pandemic. Tonight we are delighted to have a speaker here with us from Sydney, speaking about the ICU response to COVID-19. My name is Hannah Gregg. I am a medical student from the ANU and a volunteer in the COVID-19 peer support program. Joining me today is my colleague, Devashi Paliwal. She's also a medical student at the ANU. Before I introduce our speaker, I've got a couple of housekeeping notes. All attendees have their videos turned off and their microphones switched off as well. This helps us keep the sound quality clear and reduces interference. We also encourage you to ask questions. Please feel free to do so using the Q&A button on Zoom. Our speaker will answer these questions either during or at the end of the webinar. There will be a poll at the end of the webinar as well. If you've got any technical issues, feel free to email international.health@anu.edu.au, and this will be addressed after the webinar. Okay, so today's speaker will be delivered by Associate Professor Swapnil Pawar, an intensive care specialist at St. George Hospital in intensive care. He works as an intensive care specialist and is the chair of ANZICS and, as well. This webinar will cover ICU management and outcomes in Australia and tertiary ICU settings. It will also cover some of the challenges that health professionals faced at the system level and some of the positives that came out of this pandemic. With this, let's begin the webinar.
Thanks, Hannah. So if I can share my screen, I think you might have to unshare your screen first. Yeah, thank you. So welcome everyone. First of all, thanks Hannah and Devashi for this wonderful opportunity to speak at this webinar series. I'm pretty sure it's late evening for most of us joining from down under, but thanks for staying till late. And the topic that I was given to cover is around COVID-19 in intensive care unit lessons learned. Now, obviously, I'm going to talk about my own perspectives and the lens through which I saw the COVID-19 in intensive care unit, and which will be also backed by some of the data that has been published through some of the robust collaborations in Australia and New Zealand. I guess I do also run my educational website, criticalcareeducation.com.au or criticaledu.com.au, and which has actually got different podcasts which has actually covered this topic quite extensively. So if you are interested in knowing about evidence around COVID-19 or any other evidence around critical care, please feel free to visit the website. Now, as we all know, COVID-19 kind of started back in December 2019. And obviously we are now almost about to complete 2 years of this pandemic. Initially, there was a lot of struggle around or almost disbelief that this pandemic will extend beyond China. And everybody started kind of getting worried about this pandemic when Italy got hit. And the current president of ESICM, Maurizio Cecconi, when he published a video saying that everybody should now start getting ready, that was the kind of alarm bell for most of the intensive care units around the globe to kind of start really preparing. And then JAMA and Lancet and New England Journal of Medicine almost launched a weekly or weekly podcast series, and publications started coming through to understand this pathophysiology of this new disease entity, which we have never been aware of before. Now, it's not new to us in the medicine that we have not seen any pandemic before kind of thing, but this COVID-19 pandemic was quite unique in a various different ways. Now, we had H1N1 pandemic here in Australia and New Zealand in 2009. And then also we had a MERS pandemic in 2016 obviously in Middle Eastern countries, but really those pandemic did not kind of spread across the globe, and the damage that has caused by those pandemic was not as extensive as this pandemic. The challenge, the first and foremost during the initial phase of the pandemic, was to understand what is this disease process, how this virus actually affects the human body, and how does that lead to kind of spreading of the virus rapidly, and then how can we then start inventing the new treatments which then can help us to contain this pandemic. And that's why the paper which was published in Nature kind of outlines the pathophysiology of SARS-CoV-2. And obviously, initially everybody was thinking it predominantly is going to be the primary pulmonary pathology, and it will only affect the lungs. But clearly, that was not the case, as we started seeing the manifestation of COVID-19 across the whole different organ systems. One of the key mechanisms which was found that it has got the SARS-CoV-2 virus has got the spike proteins, and it has led to direct cytotoxic effect, and it has also kind of caused the dysregulation of reticular angiotensin system, and also there was a kind of hypothesis started coming out, and which has subsequently proven that this SARS-CoV-2 leads to massive cytokine storm, and that has become then the kind of area of research or the focus in order to develop different treatment strategies. Now, initially, when we are dealing in this kind of pandemic in the first place, we are quite lucky in Australia and New Zealand because of the geographical location that our ICUs were very protected in terms of we did not get to see many patients. But what we are hearing from different countries in Europe or United States, that clearly this virus can spread very rapidly, can affect primary lung pulmonary system, but it can also affect the different organ systems in the body. And the key aspect of the whole pandemic was overwhelming of the system. That means ICUs get full very quickly, and that leads to significant burden on the hospital and healthcare system, and then it's very difficult to control the mortality. Obviously, there were different extra pulmonary manifestations were reported during this pandemic with the SARS-CoV-2. And obviously, this was all kind of evolving as as physicians or intensivists were treating the patients at the same time. So there was enormous challenge at the beginning of the pandemic was not only just focusing on patient treatment, but was also focused on publishing the findings or observations and publishing those research studies. And conducting the research in the pandemic can be massively challenging. Having said that, I must say that we as a community took this challenge and managed to produce some stellar research during this pandemic. So, and if you see this extrapulmonary manifestation, realistically, COVID-19 can actually impact pretty much every single organ in the body in a various different ways. In intensive care, obviously, we mainly kind of focused on pulmonary manifestation or cardiac or renal manifestations, but obviously the long COVID, which is now, we have started to understand a bit more now. Now we kind of understand now the COVID impact lasts longer, even when the patient recover from intensive care unit and then when they go home, and all other systems get affected during the COVID, and then has got an impact on their long-term outcomes. So this is obviously not related to hospital or healthcare setting. This slide actually was taken from the Journal of Science and Total Environment. Now this is related to agro and food industry. But I was trying to find out how this COVID-19 really impacted, or what are the kind of different challenges that we faced during the COVID-19. And it's really interesting slide because it kind of, even though it's related to agro and food industry, it kind of captures how COVID-19 impacted the healthcare sector. If you look at the multi-agency innovation hubs, in terms of COVID-19 forced us to come up with a lot of different innovations during this pandemic. It may be about manufacturing different N95 masks, manufacturing different vaccines, and the mRNA vaccine, I must say, was probably the innovation of this decade. It probably missed out on getting the Nobel Prize, but it was quite interesting innovation which has saved mankind. So innovation of COVID-19 due to COVID-19 is quite interesting, and the innovation was happening across different industries and across different sectors of the healthcare. In terms of we understood the impact of digitalization during the COVID-19, and even most of us switched from regular face-to-face sessions. Maybe it's education, or maybe it's conferences or meeting. Everything has now moved online. It has got a significant impact on the climate. First time I could see the clear sky in Sydney, and there was no traffic on the roads. Waste management actually became a significant issue in intensive care unit actually. And we kind of started worrying about the waste management because amount of PPE that we wore during this pandemic was enormous, especially during the second wave. And I was just talking to one of my equipment officer the other day. And just to kind of give you the context, that the normal hand gloves that we use in intensive care, when we use the medium-sized gloves, the normal box used to cost only $5 for roughly around 100 pairs of gloves, and that now started costing $40. And medium-sized gloves are commonly used in intensive care unit on a day-to-day basis. So imagine the price is going up by 8 times. And also we're generating that much of plastic waste every single time. So there was significant implication on the financial side, but also there was a lot of implications in terms of generating the waste through PPE. And obviously we have not kind of factored that effect yet, that how much waste that we have generated through this use of PPE over the period of time. So there were a lot of technological challenges, social challenges. So social challenges is, I will probably touch base upon later on in terms of the impact on the staff. But a lot of the staff have to work in ICU, but at the same time, the kids were at school, they couldn't go to school, and they had to do the homeschooling. And the impact of homeschooling on ICU staffing was enormous because the ICU shifts were getting very exhausting with the full use of PPE for a prolonged period of time. But at the same time, when you go home, then you have to do the homeschooling. So a lot of nursing staff, medical staff, they had a significant issues with burnout, because what happens outside in society, that also impacts on your personal and professional life. Lockdown were not easy for staffing either, because once you are in lockdown, you really can't do, and you really don't have an opportunity to go and enjoy a meal or have a wind down or free time. So you're restricted to your locality of 5 kilometers, and then it was really challenging. So the COVID-19 has really posed a massive challenges to all healthcare sector, but obviously the impact on ICU was quite significant because of the nature of the work and long shifts and constant wearing of PPE throughout those shifts. In terms of the decision making from the intensivist point of view, there are several dilemmas that we faced as ICU specialists. We have to think about the allocation of resources, because obviously most of the time the ICU beds are the bottleneck for most of the healthcare systems. Sorry, because normally we saw that for every kind of 100 admissions of COVID-19 in wards, we were getting at least 10 to 20 admissions in ICU. Now, normally my intensive care unit, even the physical capacity of our ICU is 52 beds, we were funded and we had a staff allocated only for 36 beds. My hospital reached at one stage up to 100 patients in the wards, and we had 26 COVID-19 patients at one point in time in ICU. And that's just a COVID-19 patient. But at the same time, there were other emergency traumas, emergency cardiothoracic surgery were still happening in the hospital, and allocating the resources was quite a challenge, because at the same time, when you are trying to save patients with COVID-19, but you are also trying to be kind of equally you have to justify equally not allocating the bed to a young trauma patient. So it was a quite challenge. And then when the certain sectors or certain hospitals in New South Wales got really overwhelmed with the capacity, other hospitals started taking the burden. So there was a lot of interesting community or like ICU community spirit, which was kind of demonstrated during this time. We kind of shared the workload with regards to accepting the patients from different area and different health sector. But having said that, that was not easy for the families, because imagining sending the patient from all the way from John Hunter to St. George, it's almost like 3 hours drive for the family, but at the same time, it's not easy for them to commute every day. Also, from the family point of view, it was quite interesting because of the lockdowns and because of the government rules and regulations. They were not allowed to come in to hospital to visit their loved one. That means we have to quickly adopt and be flexible in terms of how we are going to deal with situations and break or dealing with the difficult conversations or breaking the bad news kind of scenarios, and everything has to go online or use Zoom. And that was also quite difficult because on the one side, you are busy in a very COVID pod, which is you're isolated from the rest of the normal ICU. But at the same time, you are in full PP and you are trying to contact or speak with the families of patients via Zoom or any other online platform. And with that, a lot of staff felt that was quite taxing, but at the same time, emotionally, it was quite draining and it was challenging. And that's why one of the things that we came out of that was balancing the physical and mental health needs for the workers. The gyms were closed. There was not enough places where you can go and do some exercise. Lockdown was quite strict during that kind of second wave of COVID-19. And that was really, really difficult. Even in terms of resource allocation or offering certain treatments during this pandemic was quite tricky. Because you have only limited resources, and then you have to justify to families and to patients why you won't be able to offer certain interventions that you might have had offered in a normal non-pandemic situation. So that was really challenging, and there are a lot of ethical dilemmas that we all faced in our healthcare settings. Also, there was another interesting where some of the families were still in denial of this COVID-19. Some of the families were still, or some of the patients were still refusing to accept the vaccine. And that also obviously created, and some of the families or some of the patients were demanding some of the alternative treatments, given that there was a lot of misinformation was out there in the media. And that also become a quite challenge for us to deal with in addition to treating the patient. So there are a lot of different challenges that we kind of came across in the intensive care unit. Now, normally in intensive care unit, it's without even pandemic, it's quite intense job to obviously resuscitate the patient, then speak with the families, and then look after your colleagues as a team. But COVID-19 obviously amplified those all challenges by at least 100 times. So those are the kind of challenges. Some of the other interesting nuances which came through, which probably were not reported yet, but a lot of staff started getting the pressure injuries with the N95 mask because they were wearing at least for 3 hours. And obviously it was affecting most of the like a facial like nose breach. So obviously there are the kind of things that also emerge. So it was quite interesting. Luckily, we got through that, and community responded quite nicely in terms of achieving that 90% vaccination. And now we are out of the lockdown and we can take a bit of breather. But those 2 to 4 months were quite challenging in terms of dealing with these different challenges. As I said before, the research community stepped up quite significantly in intensive care unit. And there are 3 different platforms that I really want to congratulate today. The first one was the ReMAPCAP. Now, Professor Steve Webb from Perth, he was kind of started this adaptive platform randomized controlled trial design around community-acquired pneumonia. So the platform was set up long time before, and this collaboration came from different researchers or different intensivists across different countries. And ReMAPCAP rapidly adopted in the pandemic, and they managed to recruit around 10,000 patients in the different domains, and they completed 50 different interventions. So they tried different interventions. They've proven the benefit of steroid, they've proven the benefit of tocilizumab, they've proven the non-benefit or the harm of some of the interventions. And that way we as an intensive care community were benefited enormously, because then we could actually practice the evidence-based medicine. So ReMAPCAP was a huge success. And I think moving forward, most of the trial designs in intensive care unit will probably shift to this adaptive, multifactorial adaptive platform design. And I think this is probably the new way that we will conduct the research. Another interesting thing which I noticed during this whole, and I was speaking offline to Prof. Webb, that a lot of the red tape or the bureaucracy was kind of eliminated during this research, because with the pandemic, the research was prioritized, the grants were given, and a lot of the time that the trial, which takes a randomized control trial, which takes long time to even start kind of conceptualizing and setting up, it was the most of those things were fast tracked during this pandemic, and that allowed to produce some of the high quality research during this pandemic. Another trial, which was a landmark trial, was the recovery trial, which came from Peter Hobby and his group from Oxford. And again, this was a massive collaboration, had a massive impact on the way we, and probably this is the landmark trial which actually showed the benefit of dexamethasone in COVID-19. And without this trial, I don't think we could have had managed to kind of contain or improve the patient outcomes significantly, especially in the second wave and the third wave. So hats off to the recovery collaboration. Again, extremely well conducted, robust research. Again, showed that the good quality research can still be done even in the pandemic settings. Because a lot of the other articles which were coming, especially when you heard about the hydroxychloroquine story or ivermectin story, a lot of this kind of trials were getting published even in some of the reputed journals without much kind of robust evidence, and that really confused not only the intensivists or not only the treating physicians, but also the patients and the community, that and people started taking those interventions or medications off without prescription in the community, which will obviously cause a lot of problem. So recovery, the collaborations like recovery and ReMAPCAP are really, really important, which has actually changed the trajectory of this pandemic significantly. And I guess that's really worth mentioning. And I think this is probably the future of conducting the critical care research, where it actually, rather than conducting a single center or single nation randomized controlled trial, there is probably the need to do this large multinational adaptive platform trials. Another important contribution from ANZIX itself was setting up the Sprint Sari registry or the database to collect the data from different ICUs in different intensive care units within Australia and New Zealand. And again, this group has done an amazing job over the last 1.5 years. Obviously, when initially first wave started, everybody got excited. We collected the data, but obviously in Australia never seen many cases in the first wave and second wave. But now with this the phase 3 of this pandemic, we managed to get the data quite rapidly, and obviously the Sprint Sari managed to inform clinicians about the patient outcomes quite quickly. So I guess this collaboration had a significant impact, and I'm going to present or share some of the data that came out from Sprint Sari very recently. So again, hats off to ANZIX and its collaborations. And another contribution from ANZIX was setting up the living national guidelines around COVID-19. The living guidelines was another important concept where whenever the new trial or new evidence gets published, all the members of the guidelines will come together, evaluate the evidence, and update the recommendations. And the living guidelines informed all treating clinicians about what is the best possible synthesis of that evidence and how we should use that intervention in setting of COVID-19. So ANZIX had done an amazing job in terms of dealing with this pandemic, and hats off to the whole ANZIC's core, ANZIC's CTG, ANZIC's leadership group for stepping up in these kind of challenging times and demonstrating that we as an intensive care community can take the lead in terms of changing the trajectory or slowing down the impact of this pandemic. So I was asked to talk about a bit of ICU admission, and this is really interesting. So a lot of people ask about how you decided to admit the patient with COVID-19 in intensive care unit. A lot of guidance came from the ANZIC's guidelines, which were published, and now there's a fourth version was recently published. And again, it's not a very hard and fast science, and it's really difficult to go by a very set or rigid criteria. But having said that, it's important to have some sort of framework or guidelines, because when you're dealing in a pandemic with the mass numbers, when there are like 10, 20 people coming through emergency department, and when the ED gets blocked with the bed or ED ends up in bed block situation, it's really important to have some sort of clear guidelines around which patients are going to benefit from ICU admission. Or which patients can be managed outside ICU in the ward setting. Now, I must say the initial kind of guideline was around, okay, anybody who is requiring oxygen around Hudson mask of more than 6 to 8 liters per minute, sats around less than 92%, or worsening trajectory, which could be either because of the respiratory rate worsening, ABG or gas exchange getting worse, or patients is developing some other systemic complications such as shock, arrhythmias, or other organ dysfunctions. And I must say, with this kind of criteria, there was a lot of variability in the response across different ICUs and different hospitals. These were the kind of criteria that we are kind of agreed upon in our hospital. So anybody who was requiring high flow oxygen, nasal oxygen, they will come down to intensive care unit because of the lack of negative pressure rooms in the ward in hospital. A lot of healthcare workers from the respiratory ward were uncomfortable to look after these patients. So we admitted a lot of patients even requiring high flow, while some of the other hospitals in New South Wales, they managed to do high flow and even non-invasive ventilation in the ward. The threshold for ICU admission varied significantly between different ICUs and different hospitals. So some hospitals, as I said, cope with starting up the NIV and tolerating FiO2 requirement up to 60 to 70% in the ward, because these patients sometimes they do get better with the BiPAP or NIV over the period of time, and then don't need to come to ICU. But in my ICU, the approach was if they require anything equal to high flow oxygen therapy, they will come down to ICU. Anything more than 50 liters and 50% FiO2, we will prefer to do early intubation. And I must say the outcomes in my ICU were quite amazing. We had like total 149 patients, and out of that we had like 24 deaths. So we were pretty, in terms of overall outcomes, we did really well. So the variability was the challenge. And I guess moving forward, as we understood the disease process with regards to what respiratory support is needed for these patients over the period of time, or if I hope we don't need to face this COVID-19 pandemic again, but in case if we have to, then we will be much better prepared in terms of having a bit more structured framework around offering the respiratory support and the location. Now, most of the COVID-19 was a single organ failure from our experience. And I must say, when you look at some of the imaging of these patients, usually you will think that these lungs are terrible. There is not much to do with these lungs because you can't really ventilate these lungs. And that was the kind of case in the very first week. But over the period of time, most of these patients got better and they got extubated and they went home. They got discharged home despite these terrible looking CT scans. A lot of the patients had pulmonary embolism positive despite being on DVT prophylaxis. So usually if the patient stays more than 2 to 3 weeks in intensive care unit, we ended up in doing CTPAs on these patients. And we had a reasonable rate of finding PE positives, and then patients went on heparin infusion and so on. But one thing I realized, just based on imaging, you really cannot decide to withdraw the care. Given the time, these patients do recover. The last week when I was in intensive care, I extubated one of the patients who was in ICU for almost 60 days. And even the CT scan or X-ray looks terrible. Patient is breathing comfortably with a high flow, 30% oxygen and 40 liters. And now he's started sitting out in chair. So he's going to the ward now. So the bottom line was, it's usually the time do help for these patients to recover. So the good baseline ICU care usually helps to reduce the mortality. And I think that was the kind of finding across the most of the Australian or ANZIC's data, that the mortality, what we observed in COVID-19 here in Australia and New Zealand was around 18%, even with the Delta wave, while India or UK, obviously the mortality was quite higher. And that's mainly because our systems in Australia and New Zealand did not get overwhelmed with number of admissions. We still managed to accommodate all the COVID patients and managed to look after them really well. We did not need to alter our nursing ratios who were looking after patients. So we still managed to do 1-to-1 nursing ratio in my ICU with intubated patients. And that was that made a significant difference, because at the end of the day, a very good nursing care is the backbone of the ICU support. And if you can get that kind of one-on-one nursing support and nursing care, all these patients, they got out without developing any significant complications such as pressure injury and all those things. So despite they occupied the ICU bed for longer than expected, most of them recovered and went home. So that was really a great learning from this pandemic, that if you get the basics right for ICU, usually you will get the good outcomes. In terms of, there was obviously a lot of publication about what actually the disease is. In the very beginning of the pandemic, Gattinoni from Italy described these different phenotypes, type H and type L. And we did see that kind of different phenotypes in ICU, where at the very beginning, patient might come and very hypoxic up to 75% saturation, breathing at a rate of 30 to 40, but talking in the full sentences. In fact, I remember the first patient that I intubated in the phase 3 was down to sats of 30% on arrival to emergency department, and he was still talking in full sentences. His CT scan or X-ray did not look terrible to start with, so it was very clear lungs, and that was quite surprising. And he did really well. We thought that he might end up in suffering from hypoxic brain injury because the sats were that low, but he did really well. So we did see some kind of abnormal pathology, which couldn't have been explained by the imaging itself. Also, what we've seen with the ventilatory support is, because the traditional approach in ICU ventilation with this kind of CT pictures is to have a lung protective ventilation strategy where we go very low tidal volume, try to give some PEEP. And having said that, most of these patients' lungs had a really good compliance. They managed to get a really good, reasonable tidal volumes with less pressures. But obviously the AA gradient was a significant challenge. And that's partly because of the pathology was more on the vascular side with this microthrombi hypothesis. These patients were not getting enough oxygen in the blood, but at the same time, ventilating them was not difficult. The magic bullet throughout this whole pandemic was the proning. So the moment we start proning patients, even when they're conscious and awake and on high flow or NIV, they started responding really well. In fact, we ended up in proning a lot of patients in the respiratory wards. And that really worked like a magic bullet, and that helped us to save a lot of ICU admissions. But also within the intensive care unit, almost 62% of the patients who were intubated ended up in getting proned, and then they responded quite well to proning. So what we know so far, this is again thanks to Sprint SARI database. So we really have in Australia like the kind of 3 clear phases. Now, obviously, the phase 2, we didn't see much of the COVID. Obviously, Victoria was probably unfortunate state, which got the brunt of the most of the COVID during all three phases. But phase 3 was quite significant, and you can see the total bed occupancy reached almost 40% in third phase, and the numbers were quite rising from the mid-June till the October. And that also obviously resulted in the cancellation of a lot of elective surgeries, cancellation of a lot of daycare surgeries, and obviously a lot of private hospitals need to be kind of closed because of that, and obviously the public hospitals were overwhelmed with a lot of COVID patients. So obviously it has kind of impacted the healthcare in Australia and New Zealand quite significantly. The data is quite interesting in terms of the total number of cases that we've seen. Obviously, the New South Wales and Victoria are the two states which kind of face the major brunt of the disease or the challenges with the number of admissions. And obviously, Victoria is still kind of having some ongoing COVID cases. In terms of the prevalence of the comorbidities, that was the kind of one of the initial thought in the very first wave of the pandemic, that we thought that if you do have a comorbidity, you are at high risk of acquiring COVID. But the data really doesn't support that much. And you can see there are three different phases, and even without any comorbidities, and younger population did get equally affected with COVID-19, even in phase 1 and phase 3. And that's why the consistent message on the television was, doesn't matter what age group you are, doesn't matter whether you do have or you don't have comorbidities, you are not invincible, and you can still acquire COVID-19 and end up in intensive care unit. So I guess that was another important lesson, that comorbidity is not the rate limiting factor in terms of your outcomes. Obviously, if you get COVID-19 and if you do have comorbidities, then chances of mortality are going to be higher, but you still have end up in intensive care unit if you don't have any comorbidities. In terms of age group distribution, there was obviously significant interesting finding there, that in the phase 1, the majority of the population which admitted to intensive care unit were age group between 70 to 79 or 70 to 80, while during the phase 3, we saw only 12.3% population in that age group coming to ICU. Whether it's mainly because of the vaccination of the aged care sector during the phase 2, and that helped us to reduce the mortality in aged care sector. That's probably the working hypothesis. But we definitely saw more population between 30 to 60 years in our ICU. So I guess obviously with the vaccination, the age group which was presenting to ICU obviously changed between the phase 1 and phase 3. And the median age, if you see, was around 53 in phase 3 versus 64 in phase 1. And also that has actually had another interesting aspect, that decision making become really challenging. Sometimes when you get 80-year-old with many comorbidities, with COVID-19, with multi-organ failure, end-of-life decisions are not that hard. When you, on the other side, when you get a younger patient without any comorbidities, with significant COVID-19, and then those discussions can be really challenging. So obviously the age group did have significant impact on how we manage them in ICU in phase 3. Another interesting finding was which variant we found. Obviously, in the phase 1, it was predominantly kind of alpha variant, but then as we kind of progress during the phase 3, it was predominantly Delta variant, but also there was unknown variant, which still we don't know about that variant, and I hope it's Delta, because we want to see that we don't have any other variant floating around in Australia and New Zealand, because as the vaccine immunities will wane after 6 months, the other variants might still pop up, and that's why we don't want too many unknown variants floating around in the community, and that 32.4% can be a concern. Again, this is the same kind of data depicted in the bar chart. So obviously the black portions are the missing data around variants. So obviously that will be available over the period of time. But the green is the unknown variant, and that has got a significant proportion as highlighted in the figure. So that is the kind of area of concern, that we don't have complete information about all the variants at this point in time. And I hope it's all Delta variant, which is covered by most of the vaccination status. Now, in terms of whether vaccines were effective or not effective, I guess it's not no-brainer now that we know that vaccines were extremely effective, and people who had 2 doses of vaccine, only 4.4% of patients ended up in intensive care unit. On the contrary, if you did not have any vaccine, the number of admissions in intensive care unit were quite significant. So again, there was no brainer there, and there was. Interestingly, there was no difference between whether you had a Pfizer vaccine or AstraZeneca vaccine. So your chances of end up in intensive care unit, if despite having either of them, were equally same. So in terms of the efficacy, both vaccines were equally effective, I must say. In terms of the hospital mortality, as you can see, clearly unvaccinated patients had higher mortality than the vaccinated 1 dose versus vaccinated 2 dose. Only 7% patients died when they had 2 vaccines, while the 67% patients died when they had no dose of vaccine. So that is obviously clear signal for the community, and this kind of data helps to kind of convince population to go and get vaccinated. And obviously New South Wales and Victoria responded quite well to this challenge. In terms of different population and how that COVID-19 impacted, and I was actually worried about the healthcare workers. So I was trying to look at those figures, and I must say that we did really, really well in Australia and New Zealand, and only 1.4% of the or 11 healthcare workers got infected in the phase 3 out of 1,828. So that is really a great achievement for Australian and New Zealand intensive care settings, because that means we not only had adequate supply of the PPE, but we also trained really well in how to use PPE, because having the adequate supply is the one thing, but understanding or training to use that properly and carrying that PPE for longer period of times in ICU is quite different. It's quite different. So I guess we as a community, we did really well in terms of wearing the PPE and taking ourselves or protecting ourselves. So that was really good. Overall, Apache is obviously the initial severity of the patient admission, what we measure in first 24 hours, and that was not really well, because that was not really high, because again, majority of the patients had a single organ failure, and they were younger and did not have major comorbidities. So Apache was not that high. Having said that, interestingly, the BMI was 31.3. So clearly the obese population was probably impacted more than non-obese population. Now, in terms of what treatment they did receive in intensive care unit, so they had obviously various treatment, but as you can say, the treatment they received in ICU varied between phase 1 and phase 2 and phase 3. And clearly that was the credit to ReMAPCAP and recovery trials, because remdesivir was supposed to be the flavor in the first or second wave, when everybody started thinking remdesivir is the magic bullet and remdesivir will cure COVID-19. And over the period of time, where more data and more research came out and said, okay, remdesivir is only useful in certain cohort of patients and only in the first 7 days. And most of the patients were coming to ICU or hospital were after 8 or 9 days of their from acquiring the illness. So obviously the value or the utility of remdesivir was almost zero in the phase 3, and that kind of clearly shown that in decreasing use of remdesivir. Now, interestingly, tocilizumab has definitely shown benefit in terms of improving the mortality, and then its use definitely increased in phase 2, but and phase 3. But interestingly, we ran out of the stock of tocilizumab in Australia and especially in New South Wales. So we have to then start thinking about what's the other agent which will help us to kind of control the cytokine storm, and that's why the baricitinib use went up in phase 3 significantly. And again, credit goes to those researchers who managed to trial these drugs in the middle of pandemic, coming up with a robust evidence, and then convincing physicians to use these drugs in the patients safely was quite impressive. So I must say, and obviously if you look at the major kind of drug which was used across all patients with COVID-19 was the steroids. So 95.3% of the patients in phase 3 ended up in receiving steroids compared to 30% in phase 1. So clearly the recovery trial was a landmark trial in kind of telling us that dexamethasone does work in COVID-19. And obviously now there are more trials are researching the dose of dexamethasone, and hopefully we'll get more information in the future about 6 milligram versus 12 milligram dose of dexamethasone. Most of the patients, because they received high dose steroids or other immune therapy, they ended up in getting secondary bacterial infections, and that was not uncommon in my ICU. We ended up in seeing different microbial flora pattern in different ICUs in New South Wales. So in my ICU, it was Klebsiella aerogenes and H. influenzae were the main organisms which caused the spit of trouble, and that's why most of the patients did end up in receiving antibiotics when they were intubated and ventilated in ICU to kind of treat secondary hospital-acquired pneumonia. In terms of the mechanical ventilation data, the SPRINT sari tells us about that. Obviously, towards the phase 3, the use of non-invasive ventilation, high flow of nasal cannula usage has gone up significantly. And you can see because there was a reluctance of using these two modalities in the very beginning of the pandemic because of risk of aerosol generation and contamination or cross-contamination or causing healthcare workers to get kind of infected. But as we got better with the PPE usage, and we understood that even we use these therapies in a single room or even in the open ICUs, we still do not acquire infection while we are using these therapies. So the confidence in these interventions grew over the period of time, and that led to increased use of non-invasive ventilation and high flow nasal cannula in COVID-19. Now, invasive mechanical, as a result of that, definitely the invasive mechanical ventilation rate dropped. And I think that was a quite important achievement, because putting patient on invasive mechanical ventilation can be challenging, not just from the resource point of view, but also from the patient point of view. It can obviously cause more harm. So definitely the use of invasive mechanical ventilation went down over the period of time. Proning, as I said, was the highlight of this pandemic, which probably force us to use proning in the future and will change how we treat ARDS in future. If you see awake proning or even proning in patients who are ventilated, was only 28% in phase 1. So people were not very keen to use proning, and everybody thought it's going to be very resource intensive. Proning 1 or 2 patients at one point in time, that's going to be maximum, and we really can't prone more than 3-4 patients. But really, we ended up in proning almost everyone in ICU, and then we got so efficient at that now. We normally take less than 5 minutes to prone any patient in ICU, at least in my ICU. So we got really very efficient in doing this procedure now. And I think this is going to change how we treat ARDS in the future significantly. And in terms of as I say, the invasive ventilation has gone down significantly during the different phases. High flow nasal cannula usage has gone up. Steroid usage has gone up in phase 3. And obviously the VV ECMO, although it has gone up significantly, that's mainly because of the total number of cases that we've seen during the pandemic. But it's interesting that we have some kind of breakthrough research in this pandemic, which helped us to change the trajectory of the pandemic. In terms of the total hospital days, so obviously this has got a significant, because initially the modeling of the bed was kind of based on the average COVID-19 patient will stay in ICU only for 7 to 9 days, and that's how we kind of calculated our bed status or bed modeling. But clearly, most of the ventilated patients ended up in staying in ICU for at least 2 to 3 weeks. So obviously, they stayed longer than what we expected. Some patients did get lucky and got extubated less than a week, but majority of them ended up in staying at least 10 to 11 days in ICU, intubated and ventilated. And some of them are still intubated and ventilated in ICUs, and they are recovering very slowly. So bed block became the really issue once they get intubated. So that was the kind of interesting challenge. And then that obviously stuffed up with our bed capacity. In terms of the age-related mortality, obviously, if you are more than 80, obviously the high chance of mortality. But realistically, it was not kind of during the pandemic. We see more less than 60 years old patients can also die in ICU. So that was obviously quite a challenging situation. In terms of different usage, as I said before, the high flow nasal cannula usage in first 7 days was quite high in phase 3. And having said that, that obviously helped us to drop the invasive ventilation. But the interesting finding was once you go on invasive ventilation, you ended up in staying till day 21, day 20. So week 3, week 4, you still might be on ventilator. So clearly there was a lot of issues with the long stay patients, and most of the patients ended up in getting tracheostomy and then slow recovery and rehab and other things. Prone positioning was as I said, in the first 7 days, quite high rate of proning. Obviously, the benefit started fading after day 10 or day 13. So most of the patients did not get prone after reaching the second week. But the first week, most of the patients who were on significant oxygen requirements ended up in getting prone. And this is a recent publication which came out literally today, at least in my inbox. Another fascinating study by Carol Hodgson and the ANZIC's group, where they looked at what is the impact of COVID-19 critical illness on the disability. So what are the kind of long-term outcome and what are the impact on the survivors? And what has been shown now that even if you are lucky to survive with COVID-19, the long-term outcomes can be still problematic, where you will end up in getting significant disability. Even though the study was obviously involved only 200 patients, so obviously it's not that did not include every single patient with COVID-19 in Australia, but even this data is quite valuable because the moderate disability is around 17%, while severe disability is around 5% of the patients. And the patients who did not have any problems with their mobility, personal care, usual activity, pain, and anxiety, depression, almost 10 to 20% patients ended up getting all those problems. So it's a huge burden moving forward on the community and other kind of clinicians in the hospitals, because all these patients are going to come back to GPs and clinics with all these different problems, and they will probably need more social support outside the hospital setting. So the healthcare burden is not going to just stop even they recovered and went home. It's going to be the ongoing problem in the future. So the COVID-19 has got significant impact, and the pandemic is still not over. What we're going to now see is a long-term sequelae of COVID-19, and probably have to start getting ready to deal with those things in the community. Similarly, when you look at these different tasks, people who did not have new disability before, they ended up in getting more disability. And not it was just the one domain, it's not just the mobility, but also in the cognitive domain and also in the emotional domain, they had a significant impact. So obviously they had struggles with controlling the emotion, then the significant increased incidence of depression, anxiety, difficulties with learning new tasks. So all those issues are going to be quite relevant coming in or will become relevant in the near future for all of us as a healthcare professionals. So again, that's quite significant. But before I finish, I want to share this kind of poem, which was published in Intensive Care Medicine Journal recently from the Milan Intensive Care Unit, where initially the alarm bells were rang, and then it was like suggested that, oh, get ready for the pandemic. And this is a beautiful poem, kind of talks about what does the dawn in intensive care really mean to all of us. it has got a different meaning to different people, especially those who work in intensive care unit as a registrar or RMO. They understand how does that look like in early morning, 5 o'clock or 6 o'clock in the ICU, and what does that dawn mean to the patient. And I guess one thing that highlighted me in this pandemic, irrespective of how many challenges are posed to us, we are, as a human being, we are quite resilient species. So we accept those challenges, we adopt, we work around it, and we come up with solutions, and we embrace these challenges, and we find the way through those challenges. So that's the kind of message that I want to leave with, that doesn't matter what happens, look at the positives out of this pandemic, and obviously that will help us to keep walking together as a community. Thank you.
All right, thank you, Dr. Swapnil. We've got a couple of questions in the chat box. If you want to take a look, I can read out the first one if you want. So the first one is, thank you for giving us a glimpse into the busy Australian ICU during the pandemic. What would you do different in hindsight?
Yeah, that's a good question. So the different thing we will do is probably work around the staffing modeling, because everybody was ready in Australian ICUs with number of beds, number of ventilators, number of dialysis machine. We invested quite significantly in those assets, but I think we did not invest enough in our staffing. And I think moving forward, if we have to face, I think the key challenge will be to invest more in human resources. Make sure that we have this wonderful human beings are well equipped and they are well looked after, because that's the key to deal with the pandemic. You can open 50, 60, 100 beds in ICU, but if you do not have the lovely, hardworking nursing staff, allied health staff, and doctors looking after these patients, you can't really win the battle. So I guess the main investment in future is going to be the human resources. Also, the other interesting now concept that is floating around is having this army of healthcare workers ready to go. Because when we look at this whole pandemic, the pandemic happened in certain parts of the world at different points in time, and really to overwhelm the system, but we really did not have resources to mobilize from other part of the country or other part of the other country to the country that needed the most. And I think that's probably sometimes something that we need to think about the future, how we staff our ICUs if we are struggling to get kind of help from the different states or different countries. I think that's, again, something that we really need to think about and do differently in the future. I guess there was a question around environmental cost of pandemic. I guess, to be honest, we did not bother about calculating the environmental cost, but I must say that the cost is quite huge, especially looking at our PPE use per day in ICU. It was massive. Even now, every time we use the masks to see the patient, and number of masks that we consume per day and then throw them in the bin, plastic aprons, plastic and gloves, the cost to the environment is quite huge. Unfortunately, we do not have the robust data to back that up yet. But I must say that sometimes we, again, need to think about in future. Yeah, so I guess I must say the cleaners did an excellent job when we're dealing with the waste disposal. We did have a robust processes around the waste disposal, so that was very thought through process. But how to generate less waste or less toxic waste is something that we need to start thinking for the future. What is the mental health fallout? I guess there are a lot of studies going on at the moment to look at this very pertinent issues. There are two ways to look at the mental health fallout. One, people who were affected with COVID-19, and one who did not affect with COVID-19, who did not acquire the COVID-19 infection. I think the lockdown itself had a significant impact on mental health, and we did see increased admissions to ICU with mental health problems or suicide or those other significant mental health challenges. or increasing the drug use. We had few patients with heroin overdose, cocaine overdose, and all those things. So I guess the pandemic itself highlighted, and again, there were a lot of media reports are coming out with the increasing domestic violence. So the pandemic has got a significant mental health fallout, and I guess there will be more data will be coming out soon in next year or so from different countries, which will be quite interesting to see. How did family members cope? Not allowed, not really well. It was obviously constant battle for ICU staff to reassure them that their loved one is looked after in ICU. But every time we used to have like kind of negotiate that, like they wanted to come in. I must say the hospital exec and they did really well in terms of the end of life care though. When we are about to palliate a patient or patient is about to die, then there will be certain precautions and restrictions. Family members were allowed in ICU to kind of be present with them. Obviously, it can't really replace the feeling of visiting every single day, but at least that opportunity was provided to those loved ones whose patient was dying imminently in ICU. So it was quite challenging for family members to cope with. A lot of people complain that there was a lot of increase in complaint about not being able to visit their loved one, which is a routine practice or standard practice in ICU. And for staff, it was very difficult because we were the messengers of that message that we can't allow you to come in to visit your loved one. So again, there was kind of impact on both sides, both on the family, but also on the healthcare workers. Has Australia been able to offer any help to ICU, help to other countries? I guess in the past, there was some efforts to go in PNG and Fiji settings, and there's still a lot of Australian doctors do go around through MSF to help other countries, but as a formal, we do not have obviously any formal arrangement, but also as a sometimes army or sometimes defense sector does kind of step in to offer some help in cyclone affected areas or disaster kind of relief settings, but obviously not in the pandemic settings. But obviously when COVID-19, defense did step in. How did the absorbing of patients from overrun hospitals to those capacity in terms of organization, was it very ad hoc? Yeah, so to start with, actually, it was an ad hoc process that will get ranked by the intensivists from the other ICU and say, can you please accept the patient because we are overwhelmed? Over the period of time, then we started having the statewide coordinator and then district-wide coordinator for patient flow, who will look at the bed capacity in different ICUs and then will suggest the intensivist to ring that particular ICU because that ICU has got beds. So then that process got kind of coordinated at a kind of state level and at district level, and which was, I think, quite useful because then other ICUs managed to then share the load. And yeah, so besides doctors and nurses, can you give us an idea about other staff that helped kept ICU running during the pandemic? Oh yeah, so there was a lot of interesting help come through from all different sectors of the hospital. Again, very interesting, like ortho registrars, which we never see in ICU apart from rounding the patient in the morning very briefly. They volunteered to help with the proning team. So we had a dedicated proning team, and ortho registrars were helping in the morning with the proning and all those things, which was quite fascinating. A lot of JMOs came out and then helped with the roster in ICU. And the PACU nursing staff, so from the recovery, they came and worked in ICU as well. So yeah, so there's a lot of willingness to come and help an ICU and kind of fill those holes in the staffing. So there was a lot of community spirit there in the hospital. Could you elaborate on the new variant that you mentioned? What information instructions if you did receive from the, so unfortunately we don't get the data on the actual variant. So as I said, that's mainly because the Sprint Sari published that, but we have to just wait and see. It will be probably available from New South Wales Health website over the period of time, but they might be still in the process of actually analyzing those unknown variants. And as they confirm those variants, the more information or more data will come out. So yeah. Where ICUs in metropolitan Australia involved in helping manage patients in high dependence areas? I'm like, okay, so I'm just trying to understand the kind of question, because high dependency area, we do have HDU and ICU combined model. But if you're talking about, we did open PACU or anesthetic recovery as our extra arm of ICU. So we ended up in opening PACU as ICU area, and then we did look after them. So yeah, so a lot of Sydney Metro Hospital or tertiary hospitals opened up PACUs. And with the help of anesthetic staff, we managed to run those as a high dependency areas. Yes. Do you think admission criteria was? No, unfortunately, there was the guidelines and they were like structured, but every hospital ended up in doing their own kind of thing with ICU admission itself. So unfortunately, do you have any information on admission? Yes, the sprint study, I didn't unfortunately mention about the indigenous, but there is that data collection about indigenous population. So yes, there is, the data has been collected, and thankfully the proportion of patients were not too high in that according to the sprint study data. Bill, have you noted any difference between the patient outcomes between rural and metropolitan areas? So again, the data is not available around rural and metropolitan area comparison. But what I know from my colleagues, and I do work in Wagga, there was not much difference. And especially when those patients got really unwell, they were kind of transferred to metropolitan ICU for extra level of support. So I don't think that outcomes were significantly different between regional ICU and metropolitan ICU, because as I said, the standard treatment that these patients received in ICU was quite standard across Australia and New Zealand. So they did benefit equally, I guess, in all kind of different settings. But yeah, we had to probably wait for the more data from sprint study. Did you get extra JMO to handle COVID patients? Did you develop medical staff or team for? Yes, so we did have COVID and non-COVID rosters separately. We did get extra JMOs from the JMO office and also from the surgical specialties, because a lot of surgeries or elective surgeries were cancelled. So the lot of we had urology registrar and trauma registrars coming and helping us with the RMO rosters and other things. We had a non-COVID dedicated teams. Even with the COVID roster, we had set rules that nobody will work more than at a stretch more than 3 hours in that kind of COVID pod. So they will rotate. So they will come out and take a break and then go inside the COVID pod. At the same time, nobody will do, especially with consultants or registrars, they won't do more than 3 days at a stretch in COVID pod. So they will have a break after 3 days and they will work in non-COVID pod, and then they will go back again after a break in COVID pod. So in just to order to avoid burnout and issues related to the PPE, especially the mask, we kind of made those changes and which really worked well. So overall, people were happy in terms of the rostering and other things with 2-day or 3-day model. And also it kind of shared the burden amongst all of us equally. I guess that's all questions.
Yeah, thank you, Dr. Swapnil, and thank you to everyone who asked the question. I'd now like to share a poll with everyone. If you could fill that out for us, that will provide us with good information about the webinar as well. And I'd like to mention our talk for next week. We're going to have Dr. Gopal talking about COVID-19 and kidney disease. So you can register for that one the same way as this webinar. On a final note, that's the end of the webinar. Thank you for attending.
Thank you.
Thank you, Dr. Swapnil. That was a very insightful talk. Do you mind staying for just a few more seconds? We'd like to take a panel picture. This is just for our social media. And thank you again for the audience. We had some really good questions come up. So thank you again. Hannah, can you
Thanks for
unshare the screen? Yeah.
Yeah, sorry.
Thank you. Okay, I'll just take a quick panel picture. Thank you, Dr. Swapnil. It was nice to meet you and very interesting talk again.
Thank you very much. Really appreciate it.
We'll be
Let me
signing
know
off.
if there's any major feedback,
Yes.
but I hope that kind of covered the audience. I'm not sure.
Absolutely,
But,
you did. Yeah, very well done. Thank you again.
thank you.
Take
Have a good
care.
night. Bye.